Hey there, it's Dr. Suchard again. This time we're going to be discussing cyclic antidepressants, correlating to Chapter 68 in Goldfrank's Toxicologic Emergencies. The learning objectives for this video are that once you've studied the related materials, you should be able to identify at least 4 receptors blocked by cyclic antidepressants, describe the clinical effects seen with cyclic antidepressant toxicity, and to outline a treatment plan for cyclic antidepressant-induced cardiotoxicity. Cyclic antidepressants, CAs, are also commonly called tricyclic antidepressants, or TCAs, based on their common chemical structure, which contains 3 rings. We see here a few of these TCAs, but there are also some closely related tetracyclic drugs, not depicted on this slide, that share common mechanisms of action and toxicity profiles. So the more inclusive term, as used for the textbook chapter, is just cyclic antidepressants. I'm going to warn you now that I'll be using both terms interchangeably. I am aware of the distinction, and I'm usually a stickler for semantics, but it's a hard habit to break to not call them TCAs. Speaking of which, TCAs are very promiscuous in terms of the number of receptor systems they affect. They block reuptake of serotonin, 5-HT, and norepinephrine, which is probably related to their therapeutic effect as antidepressants, but they also block histamine receptors, muscarinic acetylcholine receptors, alpha-1 adrenergic receptors, and others. There's very little specificity here. And many TCA side effects and toxicities are predictable based on the various receptors they block. Histamine blockade interferes with neurocircuitry promoting alertness, resulting in sedation. Muscarinic acetylcholine receptor blockade produces antimuscarinic effects like dilated pupils, dry mouth, and other features of an anticholinergic toxidrome. Alpha-1 adrenergic blockade in therapeutic doses may result in orthostatic hypotension, and with overdose can cause overt hypotension or even shock. But the most dangerous effect seen with TCA overdose is myocardial fast sodium channel blockade, and this will lead to the most important directed antidotal therapy we have for cyclic antidepressant toxicity. You'll recognize the graph on the top as the cardiac action potential, and the lower graph is the corresponding EKG tracing. The black lines here are the normal state in the absence of sodium channel blockade. We see that normally the depolarization in phase 0 is very rapid. Sodium is rushing into cells along its electrochemical gradient through the voltage-gated sodium channels, and this corresponds on the EKG to a narrow QRS complex. But in the presence of sodium channel blockers, the influx of sodium is impaired, decreasing the slope of phase 0 in individual cardiac cells, and manifesting on the EKG as a widening of the QRS complex. Now, if we want to consider the spectrum of cardiac effects we'll see with increasing TCA toxicity, the first thing will be a sinus tachycardia from their antimuscarinic effects, counteracting the normal amount of vagal tone on the cardiac pacemaker. Then, as the amount of sodium channel blockade increases, the QRS will widen, and if it widens far enough, the patient can develop ventricular tachycardia or even worse rhythms. But since these changes occur along a spectrum, we may be able to detect sodium channel blockade and start to treat it before malignant arrhythmias develop. And we also see here that TCA toxicity can prolong the QT interval, mostly on the basis of prolonging depolarization rather than delaying repolarization. And while a prolonged QT theoretically puts patients at risk for developing torsade de pointe, just having a rapid heart rate is already protective against torsade, so it's rarely seen. This slide shows the EKG changes seen with sodium channel blockade. We see QRS widening. The QRS duration here is 120 milliseconds, with normal being 80 to 100 milliseconds. And there is an atypical morphology of the QRS complex that's best seen in lead AVR. Normally, all of the deflections from the isoelectric line in AVR are downward. But here there is a significant portion, the latter portion of the QRS complex, that appears above the isoelectric line. This morphology has been described in several ways, but they're all describing the same phenomenon. With sodium channel blockade, the right bundle tends to be blocked more than the left, so the depolarization towards the right of the heart is more delayed. Normally, the right and left sides of the heart depolarize at the same time, and since the muscle mass of the left is larger, we never see the rightward depolarization on a surface EKG. But in the presence of sodium channel blockers, the left side depolarizes first, and if there's enough delay in the right-sided depolarization, we'll now be able to see it occur immediately afterward. And AVR is the lead where this is best observed, since it's a lead over the right side of the heart, AVR for right. In fact, the degree of QRS widening, the degree of sodium channel blockade, seen with TCA overdose can be used to risk stratify patients with regard to the incidence of seizures and cardiac ventricular arrhythmias, which are the most serious and life-threatening effects seen. According to this landmark 1985 study, about one-third of patients with a QRS duration above 100 milliseconds will have a seizure, and about one-seventh of patients with a QRS above 160 milliseconds will have ventricular arrhythmias. There's a characteristic toxidrome often accompanying TCA overdose. What you can see clinically at the bedside, just observing the patient, are the anticholinergic effects like dilated pupils, rapid heart rate, dry mouth and skin, altered mental status, etc. And if that's all you looked for, you'd be tempted to treat the anticholinergic toxidrome, say, with physostigmine. But even though that's what you see, that's not the important thing to treat, and such treatment might even be dangerous. We'll come back to this in a few slides. A bedside examination can tell that the patient is tachycardic, but there's no way to observe QRS widening without an EKG. And QRS widening from sodium channel blockade is the other part of the TCA toxidrome. And this is the part that gets antidotal treatment. Of course, if the patient develops seizures or cardiac arrhythmias, you'd treat those too. Sodium channel blockade can be treated with hypertonic sodium bicarbonate, and there are two mechanisms for this. The first mechanism relates to the sodium. The bicarb solution we are giving is hypertonic, increasing the serum sodium concentration. This increases the chemical gradient of sodium across the cell membranes, favoring sodium influx during depolarization. It would be possible, for instance, to simply give hypertonic sodium chloride to help overcome sodium channel blockade by the same mechanism. But using sodium bicarbonate allows us to also use another mechanism. The binding of sodium channel blocking drugs to the sodium channels is pH dependent, and they tend to bind better at a lower serum pH. Giving bicarbonate increases the pH, which decreases TCA binding to and blocking of the sodium channels. Here again, it would be possible to use a different pH buffering agent than sodium bicarb to raise the pH, but why not use sodium bicarb to use both of these mechanisms at the same time? This slide is just a reminder of the sodium bicarbonate dosing recommendations from the Goldfrank chapter. I'm not going to repeat the details since you can read it on your own and/or watch the other video in this series about sodium bicarbonate. Here's an example of what sodium bicarb can do. In the upper left is part of the EKG from a patient with severe cardiotoxicity from cyclic antidepressant overdose. This EKG is very abnormal, showing a wide complex tachycardia where the QRS duration is above 220 milliseconds, which looks just like VTach. 30 minutes after sodium bicarb, we see that the QRS has narrowed down to 140 milliseconds. Still notably long, but a whole lot better. And when the QRS narrowed enough, we are now able to see the rightward axis of the terminal 40 milliseconds of the QRS, with a prominent positive R wave in AVR. And 9 hours after starting bicarb, the QRS continues to narrow, and the rightward axis is still there, but normalizing. A few slides back, I mentioned the temptation to treat an anticholinergic delirium from TCAs with physostigmine. In fact, physostigmine was the specifically recommended therapy in the 1970s for TCA toxicity, and it had a good reputation for reversing anticholinergic delirium, which is no surprise, and even for narrowing the QRS interval, which happens because a slower heart rate decreases the amount of sodium channel blockade. But then in 1980, there was this landmark case series of 2 patients who developed asystole after physostigmine given for TCA overdose. Both of those patients had severe cardiotoxicity with very wide QRS intervals, and although they both became asystolic, one of the patients was successfully resuscitated. But ever since then, authorities have cautioned against using physostigmine for TCA overdose, or for any other anticholinergic drug if the patient shows EKG evidence of sodium channel blockade. In the early 2000s, I was very interested in figuring out how physostigmine had once been prized as an antidote for TCA overdose. Toxicologists specifically recommended it, and it must have been given many hundreds or thousands of times without publicized incident. And then suddenly medical opinion makes a 180-degree turn based upon, essentially, case report level evidence. How could this make sense? To summarize my review article, it appears that reversing an anticholinergic delirium might be done without adverse events, like asystole, in patients who have a normal QRS duration, since those patients are only expressing part of the TCA toxidrome. But why even risk it? Alright, I hope you will excuse that bit of vanity on my part. I'll be seeing you around.